So today's session is around the dual needs procedure. My name's Alicia Watkins. I've worked for Change, Grow, Live for almost 8 years. I'm currently the partnership development manager, but I've worked frontline and then worked my way up to the position that I'm in now. We've got should take around 45 minutes, I think, to kind of get through all of the slides, and then there's some time at the end for questions. I'd ask if you've got any questions, you can pop them either down in the chat or just write them down in front of you, and then we can hopefully get to them kind of at the end if we don't cover them within the PowerPoint. Studies show that around 40 to 60 people with substance misuse issues have co-occurring mental health issues. Despite this high prevalence, only a small fraction of these individuals will simultaneously receive coordinated care addressing both needs. Today, we will talk about how across Northamptonshire, Change, Grow, Live and the Community Mental Health Team have started to address this to work collaboratively towards a solution. I think the first thing to address is probably why we call it dual needs instead of dual diagnosis. Now, I suppose previous language has always been dual diagnosis, and when we talk about dual diagnosis, people understand what we're talking about. We're talking about somebody having a diagnosed mental health condition that also uses substances. But what we've noticed is across that, the diagnostic, you have to fit the diagnostic criteria to receive a full diagnosis. But in actual fact, a lot of people will display dual needs. I think it reflects a far more compassionate approach that aligns with person-centered care practices. It also allows for the possibility that the person may have both co-occurring conditions but may not have the diagnosis due to either not attending or not engaging with services. I don't really like that word, but not following those pathways necessarily in order to receive a full diagnosis. The term diagnosis can also carry a real stigma for some people. They may feel like labelled and judged. So dual needs just reflects the sort of shift from labelling an individual as having that sort of unchangeable mental health condition into actually addressing the fact that they may have some support needs, but it may not define them as an individual, and they don't necessarily need to be labelled as such. Dual needs also highlights the importance of addressing both conditions simultaneously, recognising the complex interplay between them. Why we ever needed a procedure. Mental health and substance misuse services are separately funded with separate policies and priorities, meaning that we each independently have very different priorities within that. Mental health services often require individuals to be abstinent from substances, and substance misuse services were not addressing underlying mental health needs, meaning that we work very separately. Screening for both mental health and substance misuse issues has never been consistent, and no single body was ever responsible for ensuring that integrated care, resulting in the lack of ownership over addressing those gaps. What we noticed was our frontline workers were feeding back that they were unable to get support from the mental health services. Mental health services were feeding back that people weren't abstinent and weren't able to address their recovery whilst trying to deal with their mental health. And in fact, we just noticed that there was a real gap. We also noticed through the drugs related death panel that equally that there were some learning on both sides from both substance misuse services and mental health. We knew that we needed to collaborate. We knew we needed that collaboration from both services in order to make it work. And our lead nurse, Kat Andrews, and some of the senior partners within CMHT knew that they needed to create an integrated and seamless service to all service users that had mental illness and substance misuse problem. The procedure met both the ambitions of the NHS long-term plan and the Community Mental Health Service Framework and the UK government strategy From Harm to Hope, which was a 10-year drug strategy to cut crime and save lives. The aims of the procedure were to really describe what integrated working care arrangements look like. So down to people working on the front line, what did that look like for them? It enhanced the service that people with dual needs received in Northamptonshire. One of the other aims was to reduce the stigma and raise awareness to facilitate and enhance access to appropriate intervention and minimise the risks associated with service users who presented with dual needs. Would then minimise the risk of people being passed between services and not receiving the interventions that they need. And hopefully it would improve access to mental health services and substance misuse services for those who presented with dual needs. These are a particular population that often fell through the cracks. Like we said, frontline workers as well as service users have all fed back about how they felt passed between one service to another. And in actual fact, they didn't meet the criteria for substance misuse services, and they weren't abstinent enough to access mental health support. We worked on a number of fundamental principles. That all assessments in mental health settings should screen for all substance misuse, and that vice versa, all assessments in substance misuse services should screen for mental health problems. Joint assessments between both agencies were what we would call gold standard and should take place wherever practically possible. Many individuals with dual needs required support from both mental health services and substance misuse services. And what was really important was the service to which the individual would actually present is responsible then for notifying the partner agency. So should the service user present a substance misuse service, it was our responsibility to let those partner CMHT know about that assessment, and vice versa. CMHT would be responsible for letting us know should they present a community mental health team. Additional assessment is required and must work with the case until it's completed. So if they presented with us and let's say we couldn't get a mental health assessment for 3 weeks, it would therefore be the substance misuse services responsibility to work with that person for those 3 weeks until the mental health team could come and work alongside us. If co-working was indicated, a joint care plan should be co-produced, which identifies the roles and responsibilities of each service. I think that's a really important thing for people when we're working on the ground, is to understand what's my responsibility and what's the responsibility of the community mental health team. And that's why it's part of the fundamental principles is to co-produce that plan that we work to. It helps frontline workers to understand what's their part, what's the service user's part, and then what's the community mental health team's part. And then joint reviews must be undertaken regularly for the duration of that episode of care. We know that everything needs reviewing, and actually we should be doing that jointly together. Services must respond to the need and prevent people being passed from one service to another. It's something we heard time and time again, and actually this procedure and this policy addresses that at the heart. And one of the most fundamental principles is that we will not pass service users from one to the other, that actually we will work jointly in all cases. And should a service user, let's say, not be using substances, and actually we are saying to community mental health team, you need to pick this up, we will work with them with that really soft handover, so it doesn't ever feel to a service user that they're just being passed from our service to community mental health team. It's an expectation that staff will work with the service user's motivation rather than excluding people. So again, that's for both us and community mental health team, but actually there shouldn't be an exclusion criteria that people have to be abstinent to access community mental health team. And we went really clear. So if somebody's motivated to address one of the either their mental health or their substance misuse, that we work with that motivation. So it could be that somebody doesn't want to address their substance misuse but is ready to address their mental health. That's okay. And if somebody's not ready to address their mental health but is ready to address their substance misuse, again, that's okay. We're working with that motivation to actually start creating some change, and then hopefully that service user would then be ready to address both at maybe a later stage. It means that we adopt a really supportive approach to service users. The relationship between the mental health need and the substance misuse need may change over time, and services need to be responsive to this. So in all cases, it's about that reviewing and actually changing. So should somebody's mental health need change, or should somebody's substance misuse change, that actually we're really responsive and actually create those changes for that service user. Services must also ensure that effective information sharing and communication systems are in place, and that family and carers are involved and support in providing care where appropriate. So it's really important for us to involve a person's support network within their care plan wherever possible. And this just outlines that actually that's one of our fundamental principles, is actually ensuring that that person is building that collaborative approach, not only with the services, but with their with their family and friends. Collaboration has created our outcomes, and our outcomes have created impact. So we have managed to work with the inpatient mental health ward to successfully transfer somebody directly from an inpatient ward setting into a full inpatient rehabilitation to continue their recovery. So they managed to get a level of stability within the inpatient within the ward setting, and then actually before they sorry, silence. Rather than sort of that person then having to go back to the community and then go into an inpatient rehab, we have just smoothly transitioned that person from one and straight into the rehab itself. We referred a large proportion of people who use our service to talk-in therapies. We've managed to access support for people whilst they're in crisis, and we've worked with the community mental health teams to develop shared care plans for the people with dual needs. What we actually do is we now sit in daily community mental health team MDTs. So our team leaders from across the county are fully involved and fully invested in that community mental health team meetings, where we're able to discuss joint service users and actually create those plans together. It also allows for, if we've got any challenging situations, actually we've got a place to bring them now. So our frontline workers feel able to raise kind of any issues that they've got and address them really proactively. We also recently were able to utilise a crisis house bed for a lady following a hospital detox to support her whilst waiting to go into rehab. So again, we're just being able to be really flexible to the needs of the community, thinking outside of the box, and actually by the collaboration has meant that for this lady, instead of having again to go back into the community into a situation that she wasn't comfortable with, we utilised one of those crisis beds and then actually went into rehab following that. Continuing to work together. So I think what's really important is that the collaboration has been formed between mental health services and substance misuse services across Northamptonshire. Like I said, we continue to attend all CMHT MDTs and change forums. We continue to escalate any challenges that are presented. We listen to feedback from frontline staff and service users throughout feedback forums, and we continue to evaluate growing and meeting the needs of the communities. I think from our point of view, like the change forums has actually been about involving mental health partners in substance misuse meetings as well. So not only do we attend CMHT meetings, but actually they attend our meetings. ensuring that our staff feel comfortable and confident in escalating challenges, risks, or concerns. Kind of being able to talk about them, and actually once you've developed those relationships, staff feel a lot more comfortable in raising anything that they actually need dealing with. We use a really clear escalation process to capture challenges, and ensure that constructive feedback is provided. And we also manage to obtain staff debriefs when they need them, feeding back to staff kind of like if we can or can't do something, but also the challenges and changes within the mental health service, provider context, reducing like the frustrations. So where things have changed, we're actually really proactive in making sure that that information is shared with frontline staff now. So the graph in the bottom left-hand corner is currently our clients' mental health needs are being met. This percentage is actually taken from Northants off the NDTMS, so it's from about June, but it's remained stable for a considerable period of time now, and it actually shows that we are doing really well in trying to meet the needs of the community regarding their mental health. Trauma. I think Jane, I'll answer your question just at the end. Only because it will, if I start reading it, it'll kind of put me off. But I did notice it. So the link between trauma and substance misuse is well documented. I think trauma is both a cause and a consequence of substance misuse across the UK. Addressing this link through trauma-informed care and integrated support services is essential for breaking the cycle of substance dependency and improving long-term outcomes for affected individuals. Enhanced training, funding, and public health initiatives can ensure that trauma survivors receive the comprehensive care that they need. I think when we're looking, I think trauma is often a key and an underlying factor within substance misuse. And if you notice, just pulled some stats around trauma, and you can see that more than 50% of people with post-traumatic stress disorder often abuse alcohol. Flexibility, outreach, and person-centered, I think, is we're looking forward, and I think what we've been able to do from the collaboration that we've had with mental health services is actually look forward and look at what that gold standard would look like. I think a flexible outreach approach is critical for addressing the complex overlapping challenges faced by individuals with dual diagnosis, by meeting people where they're at and addressing their immediate needs and building trust over time. That this approach will foster engagement and reduce crisis. It also promotes long-term recovery, and it aligns with the principles of the person-centered, compassionate, and inclusive care, which are essential for this vulnerable population. I think that we often struggle for time and for by working together, it really allows for that person to feel like heard. I think that both when we're talking about the complex interplay between the substance misuse and mental health, it is definitely there, and I think only by addressing it together are we able to make long-term change. I feel like I've spoken really quickly, but has anybody got any questions? I'm just gonna quickly go to Jane's question in the chat. Yeah, so one of our founding principles, Jane, is that no service user would ever get passed from one service to another. So if for instance, they weren't right for community mental health team, one of the guiding principles within this policy is actually that they shouldn't be passed from one service to another. Therefore, the mental health team have to hold them until we're able to pick them up, or vice versa. So is that support provided? So yes, again, we would hold them. So that is part of the principles, is that we would hold them until those services were able to pick them up. No matter what they were, it is literally one of the guiding principles is that we won't pass them from one service to another. Has anyone got any other questions? I feel like I've whizzed through that really quickly. The nerves of mean that I've spoken really fast. Not so much a question, but what are the views of these services on abstinence? As I don't think it needs to be the goal. No, it doesn't. So we do, depending on what the substance misuse and what the person wants, we just work towards that person's goal. I'm actually delivering a different session on Wednesday that is around the substance misuse service, if you want to come, Lee. But as part of that, if the person wants abstinence, then we will support that person to gain abstinence. But no, so that it's not a requirement for mental health services. That was one of the things that we addressed during the writing of this procedure. So often people that were accessing mental health services were like, I need to deal with my mental health service, my mental health, but mental health services are asking us to be abstinent. And actually, we've switched that around during this policy and actually challenged that quite a lot. So you're now able to access community mental health team or Mind or any other of the mental health services without being abstinent. And although sometimes we might want that person to be abstinent, we just work towards that person's goals and trying to help them live a life that they want to live. Yes, it's being evaluated. It's being evaluated at the moment. So it's really difficult to kind of say, oh, this is the impact that we're seeing, because at the moment, that's what we're actually doing, is we are actually evaluating it. I think from a service user point of view, we've had a lot of feedback from those individuals that are accessing both services, that for the first time they feel really heard and they don't feel like they're being pushed from pillar to post. But that is all qualitative data, but we haven't got any quantitative at the moment. Service users having in service development, always service user forums are always gathering feedback and being involved in kind of how we address. We substance misuse services are a part of the community mental health team co-production community of practice. I'm actually missing that meeting to do this training, but I normally attend that community of practice in community mental health team as well. So actually that we're capturing lived experience both within substance misuse and mental health services. Oh, you have to support a person who wishes to address their substance misuse but chooses not to address their mental health at that time. Yeah, 100%, Carlos. Yeah, I would be encouraging somebody to try and address their mental health, because I think that if we were doing our job correctly, we're trying to actively encourage somebody to try and address those things. But if they said absolutely adamantly, no, I don't want to address my mental health, we certainly wouldn't close the door on them. We are always open to just trying to support people in the best way that they want. So if that person just wants to address one thing, one area of their life, that's okay. Like I said, my encouragement would be for them to try and sort of at least look at it, or know that they were going to look at that in the future, only because that's kind of trying to get them to the best place that they can be. So we work with our mission is to help people live their life to their full potential. And in order to do that, somebody would have to try and look at their mental health, but we certainly wouldn't be pushing them towards that. For those in company probation services, is the communication shared with practitioners as well? For those individuals current to probation services, is the communication shared with practitioners as well? I want to say yes, as long as the person consents, Tracy. I think if they were under one of the DNR workers, they would obviously automatically be looking, and then if it was through a court order, yes. Otherwise, that person would have to consent. But when somebody enters the service, we try and look at getting as many people on that consent form as possible. So when we're talking to somebody, what I tend to say to service users that are coming in is the more people that we can talk to, the better the collaboration between services can be. So it's in your best interest that we can actually talk to each other. So we try and obtain that consent from the service user as soon as they come in. So if they've got mental health problems, even if they're not currently with the mental health team, I'd be looking at trying to get them on that consent form. And again, as you well know, with probation or with the courts or anything criminal justice wise, again, we're trying to get them on the consent so that actually the service user then has had choice in that, but they also understand that it's the best possible way to get the best care for them, is by us being able to talk to each other. I think that with mental health, with somebody's health data, that person really needs to consent to that though. So ideally we would have that consent from the service user from the off. But yeah.